Been intimately involved in healthcare reform debates, policy development, and communication with the media and policymakers for more than 20 years. He was an innovation advisor to the Center for Medicare and Medicaid Innovation at the Center, and is now the principal investigator on patient-centered medical homes evaluation studies and methods to use payment and delivery reform to achieve the triple aim and health equity goals. Please welcome symposium fan favorite, our economic and spiritual director, Len Nichols.
Well, thank you, Don. I appreciate that. It's a real privilege to be back here in Colorado. You know, I must say there are many things I could think of to be grateful for. The first is when my phone goes off in the morning, wakes me up, it gives me the weather in Arlington, where I live next to D.C., and it's going to be 92 today, and the humidity will be higher than that. But it's also just a privilege to be among you and to be out of Washington. You know, it's kind of true that it's just, I mean, it's true. The women are better looking here and more self-reliant. The men are more honest and straightforward, and there's no chance in hell Donald Trump's going to take over this place. So I feel just blessed to be with y'all this morning. So what we wanted to talk about this morning, and there's so many dimensions to this, I'm going to have a hard time containing myself, but I'm going to get off the stage as soon as I can because we've got some real talent coming. But what we wanted to emphasize was connecting systems to health outcomes. And at the end of the day, that really means connecting data, and maybe even connecting the clicker to the, okay, fine. So basically, there's a lag. The signal is going to China and back, and you know, maybe Greece, they're having a hard time with the relay. So there are 4 questions I want to start with. And I want us to keep those in mind throughout both my talk and the whole morning, okay? What outcomes do we really want to improve? Which of those can we measure? Which can we incentivize? And I would even say, and motivate, and for whom? And what can we do about the fact we can't do everything we want? Okay, and that's what this is about. Now, we could all start with the triple aim, and we'll always end up with the triple aim. Let's, everybody raise your hand. Who thinks triple aim's a good idea? It's a great idea, right? Donald Berwick and his colleagues invented it there, and you know, it was kind of funny. The IHI trademarked it, and as a consequence, when Don was in CMS, he couldn't say the phrase because something about the government, I don't know. Anyway. So triple aim, we can now say it in public, is of course what it is, right? Improving population health, experience of care, per capita cost. But when you think about what Karen just said, you think about what Don just said, you think about what the Colorado Health Foundation has come to mean, it's bigger than all that. It's really about thriving. Thriving. And when you think about it, you know, this is what we really want to do. This is an actual photograph of Sarah Porter Osborne when all the PowerPoints came in on time this year. But if you look at her, first of all, I don't think this is Photoshop. She's actually 5 feet off the ground, okay? This woman can dunk in the NBA. She's truly impressive. And she's pulling this curtain behind her with enough thread, you know, make 3 Scarlett O'Hara dresses, right? This is this big time thing, and she's happy. And this is way better than just population health. So there are a lot of people out there trying to inspire you how to do it, right? And Snoopy, of course, is always lifting his weights. But Reba McEntire is my favorite philosopher. To thrive in life, you need 3 bones. A wishbone, so you have aspiration. A backbone, so you have the discipline to do it. And a funny bone, so you don't take yourself too damn seriously along the way. Okay, so how do we measure thriving? How do we measure actual well-being? Well, these people at Gallup, you might have heard of them. They're pretty good at polling. And they've come up with some money from Healthways, a way to do a survey. And you may have seen this stuff. I don't know. I highly recommend you look at it. It's very interesting. They have 2 million respondents around the world. And they basically have these different dimensions: purpose in life, your social connections, your financial stability, security, how well you're connected to your community, and your physical ability to do what you want to do. That's a pretty good set of indexes. And, you know, these polls and surveys tell us over time, Colorado is indeed better than West Virginia. That's a newsflash, I know. And they tell you over time that Austin's a better place to live than Youngstown, Ohio. Okay? And I love this sort of multidimensional nature, and it's a very clever idea. However, it's important to remember their response rate is about 11%. So what you notice if you look at them over time, the rankings bounce around a lot because they're not really statistically representative. So it's cute, it's entertaining. I definitely recommend you think about the dimensions there, but it's not going to be our holy grail. So then there are these people, indeed economists, believe it or not, who've gotten all excited about happiness. And I'm not joking, they really are trying hard to measure, and there's some very serious science involved. If you know those names, Jeff Sachs, Richard Layard in particular, you know, those are seriously boring economists. They're very good at thinking about hard stuff and reading multidisciplines and so forth, and they will tell you that happiness essentially has three dimensions. Cognitive evaluations, how well do you think you're doing? Positive emotions about the various dimensions of your life, and negative emotions about the dimensions of your life. And then, of course, being an economist, took the survey across the world and figured out that 75% of the variation can be explained by 6 factors. Per capita GDP, healthy years of life expectancy, the degree of social support, the trust you have for your government and your institutions, perceived freedom to make life decisions, that is, can you move where you want to and do what you want to? And finally, your own personal generosity. Yes, sports fans, you're happier when you give. Not a surprise to the spiritual among you. Anyway, this World Happiness Report, I highly recommend you take a look at that. It's got a really interdisciplinary approach to thinking about these things. But let's come back to the triple aim and stuff we're a little bit more comfortable in measuring, and that is, you know, reducing costs, patient experience, population health. And what we're doing in today's conference, and this week really, is looking for Venn diagrams. Looking for the places where stuff intersects. Looking for the places where you can actually simultaneously be sure you are reducing costs, improving the patient experience, and actually improving your population's health. So I thought this little graphic was kind of useful. It shows you the vision of the IHI, the triple aim, and that is to say a triple aim enterprise. And by that they mean an entity that is actually doing everything that can be done to improve the 3 dimensions of health outcomes that we want. And so you see, of course, a deep connection to healthcare, public health, social services. That is, they take into account the social determinants of health. They take into account the social services that support folks outside the healthcare system in the community. And notice that little purple box down there. Is that a pointer? Look at there. That little purple box down there. System level metrics. I don't think you can see it. The little purple box on the left. System level metrics. That's what I want to talk to you about, because it is the system level metrics that we're going to learn to focus on and monitor and indeed, hopefully, move. Notice all the stuff on the right, individuals, families, definition of primary care, all the stuff you're used to, but the big action happens in that blue circle where the social stuff interacts with the health stuff, and then the system level metrics are the things paid attention to by a truly well-organized triple aim organization. Now, you know, when you start talking about what actually contributes to health, it's a heck of a lot more than healthcare, right? This little diagram comes from the county health rankings people, but of course it's fairly well known from lots of different contexts. But the point is, physical environment, social economic factors, health behaviors. I want to focus a lot on health behaviors, because you're going to hear some speakers later this morning that are going to talk about how to use modern tools to significantly improve our attitudes toward health behaviors. And as this simple economist would observe, if we don't figure out how to get a much bigger fraction of our population truly engaged in better health behaviors, then all the payment reform and all the quality metrics and all the excitement is really going to sort of be disappointing. So keep in mind these different dimensions as we go forward. I call your attention to, if you have not already read, this recent IOM report, which is salutary for a couple of reasons. Number one, Larry Green, yes, our Larry Green from Colorado, was on the committee that produced it. Therefore, I believe it. Number two, if you look at the cover, it's in the shape of a heart, but it has, if you see closely, the pieces are individual states. And if you pay close attention, you can see that Texas is indeed right on the edge of seceding, just like we've been talking about for quite some time. But what I like is the fact that the august IOM uses states as a unit to think about in thinking about the vital signs we should be focused on in our healthcare system. So let's spend just a moment going through these, okay? Life expectancy at birth, remember the connection back to happiness. Well-being, you know, all that Gallup stuff, but I would also say simple self-reported health status. You know, when I began my career in health economics, I was a public health service fellow in AHRQ, what was then AHCPR, Agency for Healthcare Research and Quality now, because they ran the big surveys in the United States. Then it was called the NEMIS, the National Medical Expenditure Survey. Now it's the MEPS, the Medical Expenditure Panel Survey. And all these incredibly brilliant survey statisticians and psychologists and economists and doctors, and Lord knows they all had all these degrees, and it's hard to get them to introduce themselves. But anyway, the point was they just were driven crazy by the very fact that self-reported health status performed better than virtually anything else in predicting how people did. Because it just didn't seem like it was, how could it be, what could they possibly know? Well, turns out it's actually a good idea to ask patients what the hell they think, even if it's not exactly what the doctors would measure. Overweight and obesity. We all know how important that is. Addictive behavior, unintended pregnancies. These are clearly signals of things. There's not everything, and that's the point. IOM, and I highly recommend you read this report because it really talks about how there are something like 690 measures approved by NQF. You know, HEDIS has 65, whatever it has. There are over 1,000 metrics being reported in our nation today. And I don't know what the right number is, but I'm pretty sure 1,000 is not it. So they said, you know, we've got to figure out how to pare this down. We've got to figure out how to focus, and these are the things they picked. Look at healthy communities, high school graduate rate. Now, there's a non-health thing that turns out to matter a hell of a lot. Preventive services, care access, stuff we talk about a lot, patient safety, hospital-acquired infection rate. You know, there probably is no better barometer, according to them, of how safe a hospital is. But when you think about it, as powerful a metric as that is, it's kind of hard for today's systems to incentivize it. So as perfect a model metric as it may be, we have not yet built the connections to enable us to incentivize that properly, along with some others. And that's kind of the point here. We want to think about how to do better at that. And what the IOM is doing is saying, okay, let's shoot for this stuff. You keep going, and you find preventable hospitalizations. Again, something that is close to being measurable. We have different ways of doing it. It's close to being incentivized for some people, right? But again, to whom do you make the incentive contract? You can't blame a hospital for admitting somebody who's in uncontrolled diabetic shock. It's not the hospital's fault, right? In a way, something like admissions for uncontrolled diabetes is like a system failure, right? And that's what I'm trying to say. So how can we move to a world in which the whole system is incentivized as opposed to any individual piece, where it is the system as a whole that both will benefit from the improvement, not to mention the patient, but the system as a whole will share in the cost, and the system as a whole then has to be figured out how to connect. And that's where the rubber meets the road. Okay, well, you get the idea. We can keep going. I do want to call your attention to the last two. Health literacy rate and social support. Now, the IOM freely admits we don't really have a great way of measuring either of those, but they also say we really need to think about improving our ability to do that, because those very well could be incredibly important barometers of the capacity of our system to improve itself over time. So this is a little chart from the IHI itself, which sort of takes the version, their version of what the IOM would do. A little bit more specific, maybe a little bit less ambitious, but when you get right down to it, look at, population health mortality. Again, it's life expectancy, years of life lost, all that stuff. The patient experience features very prominently, and then these sets of measures: safe, effective, timely, efficient, equitable, and patient-centered. I personally prefer David Ballard's reformation of that, called STEEP, right? If you can do it yourself: safe, timely, effective, efficient, equitable, and patient-centered. What David has done with his colleagues at Baylor, who are right over there, and David's embarrassed me to do this, but they are right over there, that's really how you connect an institution that is a triple aim enterprise there at Baylor. Now it's Baylor Scott White. So there are ways to connect these things, but they're not done as widespread as we would like. David's book will help you if you're interested. But anyway, total cost per member of the population. Again, we can measure that very well if you're insured. We can measure that very well in total, but it's really hard to get incentives tied to total cost of care for the total population, and of course hospital and ED use. So this is my little version of what can we really do in the real world, and where do I think we should focus. Start with thriving at the top. I put a question mark because I agree I haven't convinced you yet, but I am going to try throughout the day and maybe in the bar later tonight. The metric I would submit we are taught by IOM to focus on is obesity. Okay, fine. So that leads to diabetes. We know all that. And the thing we tend to measure are things like admits for uncontrolled diabetes. That we can do. It's a PQI from HRQ. Every hospital has discharge abstracts from which you can extract this stuff. But of course, the way you control it is you keep hemoglobin A1C under control, and the best way to do that in the long run, of course, is diet, exercise, and in that italicized word, motivation. All right, so the question is, who can we get to do this? And it seems to me we have hospitals, we have doctors, we have plans, we also have governments setting rules for all the below. But all of them ultimately connect back to the patient, and what I'm trying to figure out is what metrics, properly incentivized, for whom can give us the power to affect at least the stuff on the left-hand side of that flow chart. And if you think about it really hard, if you include family and community, that is to say, you take a much more holistic view of the patient, because it actually does, of course, reach back up into the family and the community, the social structures in which that family lives, right? And then you think about what are the tools you have to do it. Right now they are patient-centered medical home, which is a great idea. It's an incredibly rich array of experiments that are going on around the country, public and private sector, many different forms, basically coming down to incentivizing a primary care practice to try to reduce total cost of care through care improvement. Okay, lots of different variations on that. ACOs, of course, accountable care organizations, that would be the global integrated system, maybe. Could be virtual, could be under one ownership structure. But again, incentivized to reduce total cost of care and improve total quality. Shared savings are the tactics that plans can use to motivate clinicians to become more efficient. And all of those tools are what we're trying to get to do to deal with the left-hand side of that thing. But of course, the game is really, can we sufficiently motivate and sufficiently improve and sufficiently optimize the diet and exercise and motivation part to cut short the right-hand side, so that over time we reduce the percentage of our population that ever gets in that awful cycle. And that's where you get thriving. Okay, that's where you get where you want to be. That's where you get to where Karen wants to take this foundation. So what am I talking about? Well, I want to think about 3 different dimensions of metrics. There are things we desire, there are things we can measure, there are things we can incentivize, and what I'm saying right now is that little Venn diagram is where we are. Okay, and what I want to do is expand that Venn diagram. And what you should be doing is thinking about ways to expand that Venn diagram with me. And the good news is we got a lot of people who can help us coming pretty soon. So what are the challenges and opportunities we face? Well, I submit to you, the thing we know we have to do is improve the actionable evidence base on what affects behavior and outcomes. Right? I have probably spent more time this morning talking about motivation and behavior than economists are prone to do, because I'm getting old and I'm getting desperate. And like Ron, I'm a little bit cranky from time to time. I admit to that. You know, it is interesting how impatient indexes change over time. But it's because I figured out all the tea and shine and all incentives in the world are not going to work unless people are properly motivated. Duh. But, you know, economists are slow. But we've got to first figure out what's working now, what can we improve, what can we spread. Gosh almighty, we need to integrate enrollment claims and clinical data. Now, your all-payer claims database right here in Colorado is, in my opinion, one of the best in the country. Your website certainly is the most user-friendly in the country, and it enables us to do a lot of drill down that you cannot do in most places. But what I'm really talking about here is connecting every claim to every clinical record so that everybody can analyze both the financial and the HEDIS stuff along with the clinical outcomes. And really importantly, link the data and incentives to providers and to patients. How about giving patients some of the shared savings? How about using different ways to motivate patients that, in essence, makes them a partner in this conversation over time? And this is what I'm really pleading for and trying to work out in various ways. Some of those SIM projects around the country, State Innovation Model, I know y'all are in testing phase, and we in Virginia are a little bit behind, so we're doing design, but we're trying. And we're having these conversations about how to build collaborative incentive and motivational structures. Right? Let's go back to this idea of an uncontrolled diabetic admission. That is a system responsibility and a system failure, all right, if it happens. So why not figure out a way to acknowledge that if we reduce those kinds of admissions, there is going to be some savings, and gosh, why couldn't we figure out a way to share those savings across all of the participants in the local system, including the patient, who can contribute to that outcome? That's what I mean by building these collaborative incentive and motivational structures through all the stakeholders, including government. Obviously, don't have to preach to this crowd very long. Broaden the focus beyond health system to the social system, because we're never going to get where we want to go unless we get fully integrated in the social system world. And then simplify. I know it's kind of contradictory. Throw all this stuff at you and say simplify. Simplify, but simplify is about focusing on what really matters. So I know it seems really complex. And I know if you try to solve it all by yourself, you're going to throw up your hands and say there's not enough math in Gilead to pull this off. And you can get depressed and just sit on the edge of a labyrinth. That is true. But just remember, if you can't see the forest for the trees, maybe you need to change the way you're looking. Maybe you need to try what's called systems thinking. Okay, you know what a complex adaptive system is? Well, you know what the most salient example of a complex adaptive system is? It's a human being. And the thing about complex adaptive systems, you got all this stuff going on at the bottom. They're called agents in the slide. All these different metrics and all these different ways to think about stuff. You got these feedback loops that are going on. But if you focus on what really matters, then you can discern the regularities that can drive you to the promised land. Okay, and it is learning what those regularities are that help you stay focused. So I submit to you, ask yourself this question. If what you're focusing on today does not lower cost, or does not improve the patient experience, or does not improve patient care, forget it. It's not important. It's not worth focusing on. And the good news is you're going to have 3 of the best regularity examining people in this country in about 30 seconds. All right, so let me stop and bring you Indu Sabaye. Indu is a